So I'd like to just let you know who else works with me on this project, particularly Kay and Emma, who have been the main interviewers and data analysis researchers for this project. Loros, the hospice that I work for, actually funded this part of the project, but it's continued under funding from the Motor Neurone Disease Association. So what do we know? Just a very brief summary about the use of NIV. We know that respiratory muscle weakness in MND leads to hypoxia and hypercapnia with lots of different symptoms. That if that's not managed, that will lead on to death, and indeed most deaths in MND are due to respiratory failure. We know, however, that NIV may improve both all of those symptoms and improve the length of survival, and that's from a randomized controlled trial and a systematic review of other work. In the UK, NICE, the National Institute of Clinical Excellence, is the body that approves treatment, and they support its use for patients. And in part due to that support, in the past 11 years or so, there's been a 3 to 3.4-fold increase in the use of NIV in the UK. We also know, however, that at least in the UK, some people who use NIV, and by that I mean become very dependent on it, so that even just a few minutes not using the NIV will lead to profound symptoms. So some of these people will wish to stop its use and no longer have it continue. If they wish to stop it before they've reached that point, then they can stop it themselves. We're talking about people who get profound symptoms and distress if they were to stop it for any short period of time. Going back to the NICE guidance, we know that NICE has recommended that discussion about how NIV might be withdrawn and the circumstances that patients may or may not wish for that to happen in need to be discussed at various points, perhaps before it's even started, although there are difficulties in starting NIV which make it hard also to discuss the negative points of NIV. We know that obviously we should discuss it when people are asking about it, and perhaps there is a need to discuss it and instigate that discussion from the healthcare professional side as the patient's deteriorating in other ways. However, NICE also identifies that more research is needed to clarify the most acceptable methods of withdrawing such treatment, facilitated and managed. So prompted by experiences in my own clinical practice and that of my colleagues, about a few patients that had requested this, we sat down and we talked about our experiences and we identified some of the key what issues. If those of you are familiar with the Driscoll model of reflection, the what are the issues, and this is our summary of those. And we went on to want to explore some of these issues in a wider pool. So we wanted to know the experience of other doctors. So we've now undertaken an interview study with doctors who were involved in the withdrawal of non-invasive ventilation or sometimes invasive ventilation at the request of a patient with motor neuron disease in the past 5 years. And we have interviewed 20 doctors, and they come from a range of specialties. So most of them in palliative medicine, surprisingly, none in anesthetics, 1 neurologist, 3 respiratory doctors, and 3 GPs or family medicine doctors. And we asked them just to talk about their last or most memorable patient as a way of starting the interview. Our analysis of the data, this is the whole of the thematic map. For those of you that do qualitative research, you may be familiar with thematic maps. So the doctor's experience at the centre, and I'm going to talk about the bottom left-hand side aspect of this thematic map, the communication and the capacity issues that have emerged from those findings. But it's just one small section of the whole findings. So overall, recalling these events, they were affirmed really as being very rare, but they were also affirmed as being extraordinarily memorable. So even after 5 years, it appeared the doctors were right back in that situation. Explicit details of aspects were recalled from several years ago. And emotionally, the tensions and the feelings that the doctor had of the situation were really very vivid, but the detail of the logistics were much more variable in their recall. So focusing on that aspect of communication, one of the key things is that communication for patients appears to be a real trigger for requesting that the NIV may be withdrawn. So many patients specify the loss of their ability to communicate as a time when they would want to stop. So specifying that in advance, either through discussion or through writing it down. Being able to communicate was seen by patients as a key element of the quality of their life, and loss of that ability was a tipping point when the quality of life was too poor to want to continue with that treatment, that it no longer enhanced their quality of life. And patients clearly feared loss of control over their care and treatment that losing communication was going to bring with it. And here are some direct patient quotes from the doctor. So he'd always said, absolutely, as soon as I can't communicate, I want you to stop things. He said, elimination of the most important thing is my ability to communicate, which I now do with my eyes and a communication board. In the event that my disease progresses to a stage where I'm unable to communicate my needs and lose the ability to have any control over my decisions of my care. So that person had communicated that painfully through the communication board that he was using with his eyes in that amount of detail so that the doctor knew what his wishes were. Obviously within the limitation of the breaths that the NIPI was giving him, and actually he really loved talking. That was a big part of what made him tick. And so we had a really good discussion about his end-of-life needs. So I hope that just gives you some of the flavours of the complexity and what patients are thinking about communication. One element that came through was that because of the difficulties in communication, the decision-making has various levels of complexity in it, but one of them is that it loses its nuance. So very often it's resulting in yes or no answers to questions rather than being able to ask very open questions. So he's lost the ability to move his eyes to the left. He's only communicating by moving his eyes to the right, and he's tired. Another factor, the fatigability. So the first 2 times it happened, it was kind of, oh God, he's moved them. But it was weak, and I remember looking at them and saying, that's not enough. We think he's saying yes, but it's not enough. So then we went to him again, and we got 2 movements to the right, which we were happy he'd done. Then we gave him a rest, and we did the reverse board thing. We did the kind of negatives. So we kind of then confirmed it, and we were all happy that he'd said, by implication, said yes. So that was a story of one patient. Another one. His speech was much more difficult, and we had to use a number and a letter board. And he laughed at us often if he was spelling out the word and you couldn't anticipate what he was saying. But getting a view from him was much more difficult. And he perseverated a bit. And if you missed a letter, he'd have to go all the way back to the start of the word. And it took a lot of his energy. Some more patience. He was sitting up in his wheelchair with his NIPI on and still able, just about, to have a conversation. And you know, if you paced it for the breaths, his expirations, he was too tired. So he answered yes, he wanted it turned off, but we couldn't get another answer out of him, couldn't confirm, probably from fatigue. So she was still sort of able to squeeze their fingers and able to acknowledge that they were there, but not able to have an in-depth conversation about what to do next. So she was competent, or rather that she could still communicate, although it was becoming increasingly difficult. She could still write, she could still nod, use hand gestures, and so we had that conversation of, you know, you're coming towards the end of life. So I hope that gives you a feeling of what the doctors were experiencing in their need to communicate with patients and the patients' difficulties in that. And part of the pressure on some of the doctors was the enormous amount of time that this difficult type of communication, that this very sensitive area of communication can take. And one of the doctors, who was a GP, said that he communicated with his board, and he could spell things out. You could go there to do a visit and he wanted to say something and you'd be kind of, oh, I've got 3 visits. And there's an A, a B, was that a C? Oh, let's start again. And you think, oh God, how long am I going to be here? I'm sure that's a very familiar setting for some of you. So there was something about having the conversation, and then there was expressions of using interaction with the patient, communication interaction, to know whether the patient really had capacity to make this decision, or whether their written statements or previously stated statements came into play. It was very difficult to tell whether his blinking was meaningful or not. Communication was profoundly challenging. Another patient. You do your damnedest to get consent and to make sure that consent is valid consent by testing it in various ways. And you have people watching you do it who can then witness that you've done it right and test it, yes, yes, no, give them a negative, everybody happy, okay, fine, we'll take that as read. Another part of the difficulty in communication was being able to interact with the patient to understand their level of distress. So my concern was that I couldn't get any feeling of response from her at all. Excuse me. So it really was as if she was locked in at that stage. And there was a feeling of, when we do come to withdraw, how do I know if she's suffering? Because I won't be able to recognize that if she's not able to communicate, to express that. I think the main issue was just not knowing, is he comfortable or not? He's not able to communicate if he's comfortable or not, because he appeared quite comfortable. And yet he was, with his eyes, saying, I feel terribly distressed. Another layer in this communication scenario was the reliance on the family, and by implication, the enormous potential burden and distress to the family. So in some circumstances, they were acting as an interpreter for the doctor. And through his wife, he communicated the fact that, and in fact had used these very words, that he was going to withdraw his consent to treatment because, being a very educated man, he realized that this was the legal formula for phrasing what he wanted to do. He was able to speak, wasn't always clearly intelligible, and his wife was the best able to interpret. Sometimes things happen before we get there. His wife had already written down some sentences that he had said. So what we did was we negotiated a way of us communicating with him and to make sure that he didn't have to say a huge amount. His wife was very helpful with all of that. He was able to vocalize a lot of noise and indicate distress and disagreement just with his noises. And he had eye blinking, and he was blinking for the discussions. Sometimes the family are actually involved in the decision-making itself, and I'll skip through that one so we can move to the conclusions. Sometimes they actually tell us when it's time that the patient wants to make the decision. So they may call in the doctor and say, it's time, doctor. So the conclusions from this piece of work are that the loss of the ability to communicate would seem to be a key factor in patients' decision to withdraw from ventilation. Doctors in the study went to extraordinary lengths to ensure they understood patients. Early and clearer communication can make some aspects easier. Profound difficulties in communication and high levels of fatigability meant this was often extremely time-consuming and needed sophisticated communication strategies. And the family are often very intimately involved in interpreting, helping facilitate the discussion, and maybe even identifying the point of timing of the withdrawal. Thank you.